The goal today was to talk about coronary artery disease. So what I want to talk about is sort of all that we need to know about coronary disease in terms of what it is, what are the risk factors for it, how do you prevent it, how do you diagnose it, how do you treat it, what does this all mean. Feel free to, you can ask me questions in the middle if you want, you can ask me questions at the end, whatever makes it easy for you, we'll do it that way. This is a picture of a heart, and what I wanted to first start with was just first say what are coronary arteries. And some of you may know a lot about this already, so excuse me for going over it a little bit too simplistically, but I wanted to start with that. So this is the heart here, okay, and it sits in the chest wall cavity. And what you see is you see this big tube coming out of the heart, and that's the aorta, okay, and that pumps the blood to the rest of the body, to the brain, through these arteries up here, and then it makes a turn and goes down, and all these little branches come off that supply blood to the rest of the body. And the heart itself is a very strong muscle. You know, each minute it beats anywhere 60 to 70 times per minute, and you say 60 minutes in an hour, 24 hours in a day. So it does a lot of work. So it's a very strong muscle that needs a lot of oxygen and a lot of nutrients for it to do its work. And that's why you have the blood vessels, which are the ones in the red, which supply the heart with oxygen and nutrients, and those are called coronary arteries. So all of us have three main coronary arteries. One on the right side here, which is called the right coronary artery, and there's one that comes off on the left side, which branches into two arteries. So we have two on the left, and we have one on the right. And then you have small branches that come off of the main arteries. So those are the coronary arteries. And from name standpoint, if you've had prior procedures or may know about it because the relatives have had stents put in, things of that sort, the right one is called the right coronary artery. The left one starts out as what it's called left main coronary artery, which is a short branch, and then it diverges into the left anterior descending artery, which is the one that comes in front of the heart, and that's the main artery that supplies the majority of the heart muscle. And there's one that's called the left circumflex artery that goes to the side of the heart, and I have a second picture to show you that. This is the left circumflex artery here. It kind of wraps around. So we have three main arteries and smaller branches. Now, those are coronary arteries. And what is atherosclerosis? Atherosclerosis is what leads to coronary artery disease. And I want to talk a little bit about what atherosclerosis actually is and how does it start. And so what it starts in the coronary arteries, you have fat and cholesterol that deposits in the wall of the arteries, and that leads to plaque formation. And over time, you have a little bit of calcium that deposits in there as well, and you have hardening of the arteries, plaque formation in the coronary arteries. That is atherosclerosis, and atherosclerosis leads to coronary artery disease. So that's how the process starts. Now, it doesn't start overnight, okay? It takes years to decades for it to form, okay? So, people who have coronary artery disease have it for a long time. It's just that it takes a long time, and then all of a sudden it starts acting up when it hits a critical threshold, or if you have a plaque rupture, you can have a heart attack. And I'm going to go through the differences in coronary artery disease that's progressive versus heart attacks. How do you differentiate the two? I think it's important. The other thing that's important to know is atherosclerosis starts as little fatty streaks. So cholesterol deposits into the arteries, and then it starts as little fatty streaks. And what we don't realize is that it starts very early. So people in their adolescence years, teenage years, you start having fatty streaks. They have done studies where autopsy studies of people who are in motor vehicle accidents, and they take a look at their aorta, and we are all surprised that people who are late teenage years, early 20s already have these fatty streaks in their arteries. So I think it's very important to, and now not everyone has them. It depends on your risk factors, your lifestyle, things of that sort, diet, but it starts very early in the process. So I think you really have to start working or acting on it early on to prevent it from becoming much worse of a problem down the road. So now these are a couple of pictures to show you what atherosclerosis is. Forget the writing because it's too small to project, but This is a normal coronary artery, and you can see the lumen is nice and large and is smooth. The surface is smooth and is widely patent. What can happen is over time, all this yellow stuff that you see is plaque. You have cholesterol and you have fat deposits into the wall of the artery, and you have all of these plaque buildup. So you can see the lumen, or the opening, has gone from this to this, and the opening now is much smaller. And that's what's progressive atherosclerosis is. That's what plaque formation is. And then what you'll notice is that, well, what's the difference between this artery here and this one? Well, there's a big clot, which is red, in the middle of the artery. So something happened where this person had a lot of disease, but still had an opening that supplied the blood flow, but something happened that led from this to this, and now all of a sudden complete blood flow is blocked to that part of the heart muscle, hence you have a heart attack. And I'm going to go through exactly how that happens. This is another slide which is a little too small, but what it shows here is that this is where the artery is open. Then you have this yellow stuff forming on the bottom, which is the plaque formation. And then when the plaque ruptures, which is that little volcano type of picture here, that leads to a complete occlusion. And people who have a tendency for these plaques to rupture, unfortunately, the body has some inflammation that makes them susceptible for those plaques to rupture again and again. So if you have a heart attack, you're at much higher risk of having another heart attack, just because there's something about the body that the plaques rupture and you're at a higher risk. Now this is a little bit of a zoom up of how this happens. So in the wall of the artery, so this is the artery, and you're cutting it in half, okay? And you're looking at the wall of the artery. Within the wall, you have plaque formation. So all the yellow stuff you see there is fat, macrophage cells, cholesterol deposits, and that's where plaque starts. And for the most part, it's not an issue. Normally, those type of plaques only become an issue when the blockage is 70% or greater. If you have a 40, 50, 60% blockage, the body adapts very well, and it can still provide enough blood flow, and you may not even have any symptoms and may not realize it. But those plaques, once that smooth surface over that, if that ruptures for some reason, and why does it rupture? Well, inflammation. If these plaques have a lot of inflammation in there, that smooth surface over it may rupture. Now all of a sudden, all of this nasty looking stuff is exposed to the bloodstream. Before it was hiding under a nice covered smooth layer, now it's exposed to blood cells, platelets, and all of a sudden everything starts sticking to it because it's not smooth anymore. It's a rough surface, everything starts sticking to it, and voila, you go within a matter of seconds to minutes to 100% occlusion. So you may go from a 20, 30% blockage to 100% blockage in the matter of seconds, and those are the massive heart attacks that you hear of in the middle of the night or early morning hours, and those can happen. And you may come to see me and be perfectly fine, and I say, okay, your stress test looks okay, you're fine, and the next morning you may have a heart attack because those plaques, and unfortunately we're just haven't become that good to really identify plaques that are vulnerable to rupturing. And there are things that I'll talk about later that we can try to do to prevent some of that, but that's how those processes occur. So now let's talk about what are the risk factors for coronary artery disease. The traditional risk factors are men over the age of 45 get 1 point as a risk factor. It's an absolute risk factor for heart disease. And women over the age of 55 are at risk for, or they get a risk 1 point for a risk factor for heart disease. Then the second is family history of heart disease. Now, as we all know, some of us have bad family histories, and there's heart disease runs in the family, and there's something to be said about having multiple relatives who have heart disease. But in terms of having the strongest risk factor, if you have a first-degree relative, a dad, mom, brother, sister, who is a male who is less than 55, or a female who is less than 65, when they first find out that they have heart disease, when they've age of first heart attack, those people are particularly at a higher risk of having early coronary disease. Other risk factor, as you all know, smoking. It's just terrible. I mean, the risk of having coronary disease if you're smoking is tremendously high than someone who doesn't smoke. high blood pressure, low good cholesterol. So more so than even high bad cholesterol, low good cholesterol, which is called the HDL, if that number is less than 40, you have an absolute risk factor for early heart disease. It's a marker of early coronary disease. And if you have diabetes, in the medical community, we treat those patients as if you already have heart disease or you already have coronary disease, because those people are so susceptible to forming atherosclerosis that we treat them as if they already have coronary disease. Now, other risk factors. So high cholesterol and high bad cholesterol is a risk factor for coronary disease. Obesity. Now, there's something called the metabolic syndrome, which we are, unfortunately, in the United States, beginning to appreciate more and more. And it's the constellation of symptoms, which is dependent on insulin resistance. What happens is the body keeps on pumping out more and more insulin, and the cells, the muscle cells, just become resistant to it. They can't metabolize the sugar, so you have high sugars flowing in your bloodstreams, and it leads to atherosclerosis. So what is metabolic syndrome? You may hear of that name. Metabolic syndrome is when you have insulin resistance, which leads to diabetes, you're overweight, you have high blood pressure, and you have dyslipidemia, meaning you have an elevated cholesterol and a low good cholesterol. So those constellation of symptoms, if you have those combined, you're particularly at a higher risk of having coronary artery disease. And the last is chronic kidney disease. If you have renal failure, you are at much higher risk of developing coronary disease. So then, well, those are the risk factors. So then the next question becomes, well, how can I prevent coronary disease? Now, we don't have any control over our sex or our age and our genetics. So those things we just don't have control over, and we have to live with our risk factors based on our genetics and our aging process. But there are things that you can certainly do. So diet and exercise, everyone says it, but believe it or not, this really has a lot of impact on your risk of coronary disease. In terms of diet low in saturated fat, so decreasing your total saturated fat intake and increasing the fiber in your diet, so a lot of fruits and vegetables. People who eat fish, if you can put that into your daily dinner plans for about 2 times a week, that has significant benefit. People in Japan don't have a lot of coronary disease. They eat a lot of seafood out there. Now, fish oil doesn't necessarily have equally as good benefit as just eating fish. And so I usually recommend that as long as you eat fish, if you can just put that into your diet, that will do a lot of good. Obviously, if you're smoking, smoking is just a terrible habit, and it's very addicting, and it's a disease. And people say, well, oh yeah, why don't you smoke? Why don't you just give up smoking? Well, it's not very easy to give up smoking, and I think it's something that takes a long time, and effort through family members and healthcare workers to really give up smoking. But clearly, if you give that up, you cut the risk of having a heart attack by about half. Other things, so those are the dietary modifications. In terms of exercise, so 30 minutes a day, 5 days a week. And it is individual dependent. Someone who is very healthy, who enjoys running, may do it. But at the same time, even if you walk at a brisk pace, 30 minutes a day, 5 days a week, believe it or not, your risk of having a heart attack or a stroke will be tremendously reduced. The key is to do what your body allows and push yourself just a little bit over that. So you want to make sure your heart rate is high and you sweat by the end of it and you feel like you've had a good workout. If you're just taking a leisurely stroll, now that's better than just sitting on the couch and watching TV. However, it won't do as good for your heart as if you were to push yourself and sweat a little bit and say, oh boy, I'm a little tired now. I hit a good 30 minutes of exercise. And it can be any aerobic activity that you enjoy doing. The other thing is, in terms of prevention, is early and regular screening. People don't appreciate this enough, and they find out they have coronary disease when it's already too late. They've already had their first heart attack. If you go to the doctor regularly and get yourself screened, you can pick your risk factors up early and you can intervene on those early. So what do we screen for? Well, we screen for your blood pressure, a full cholesterol profile. Now there you can get a little bit more fancy and do a lot more things that we can talk about later, but at least for a starting point to see where your risk is, you need to get a full fasting lipid profile. You need your fasting sugar to make sure you don't have diabetes or that you don't already have impaired glucose tolerance, which is a risk factor for developing diabetes down the line. If your sugar is already becoming elevated, you can intervene on that early enough before you get diabetes so that you can prevent it or delay it from onset. And there's something called the hemoglobin A1C. If you are a diabetic, you know all about it. That's checked frequently to make sure your target sugars are well under control. And your body mass index. Believe it or not, people get used to their weights after a while. Now there's not a, weights are difficult in terms of losing weight is very difficult, but you may not know exactly where you fall. If you don't know, body mass index of over 25 is considered overweight, and people may not know that. Or over 30 is considered obese. But I think if you see it on paper at each visit what your weight is and what your body mass index is, that may clue you into saying, okay, I better start doing something about it to lower your risk. So what should your targets be? I talked about all these screenings. Well, what numbers do we look for? First is blood pressure. Your systolic blood pressure, which is the top blood pressure, should never be over 140. Consistently, it should be ideally in the 130s, but never should be over 140. And your bottom number, which is the diastolic number, should never be over 90. Whether you have coronary disease or you don't have coronary disease. If you have coronary disease, we need to even be more aggressive to keep that low to prevent the heart from doing all that extra work. What happens with high blood pressure is that high blood pressure is basically just a measure of pressure in that big tube, the aorta, that the heart is pumping blood against. If the pressure is really high there, the heart's going to have to do extra work. And you can imagine the ramifications of that. Each time, every minute, it has to do additional work. It leads to problems. Now, in terms of your cholesterol, well, what numbers are we looking for? The total cholesterol should be less than 200. Okay, there's no reason why the total cholesterol should be higher than 200. The triglycerides should be less than 150. The good cholesterol should be over 40. And the bad cholesterol depends, the target value depends on what your risk factors are. If you already have heart disease or if you have diabetes, ideally you should be 70 or less, okay? If you have 2 or more risk factors, and those risk factors are the ones that we talked about earlier, if you have 2 or more, then your bad cholesterol should be less than 100. And if you have less than 2 risks, just 1 or no risk factors, then 130 should be your target. How about sugar? Well, your fasting glucose ideally should be less than 100, okay? 100 to 110 is where we need to target our fasting blood glucose to be. If your blood glucose is already over 110, then you're already in the impaired glucose tolerance range, meaning you're pre-diabetic. You have a higher chance of becoming a diabetic in the next few years. If you already have diabetes, then you know that your hemoglobin A1C needs to be less than 7. Now, body mass index. Normal is 25. Now, what is body mass index? It just basically adjusts your weight for your height. So you take your weight in kilograms divided by your height in meters squared, and that gives you the body mass index. So less than 25 is normal, 25 to 30 is considered overweight, and obesity is over 30. The next step is, well, what are the symptoms of coronary artery disease? And that's what we should talk about next. Now, this all depends on what is the etiology, okay? Now, I'm going to talk about the etiology or the causes first, and then we'll talk about specific symptoms. So you have a spectrum of things. You could have what is called non-obstructive coronary artery disease. Those are the people with 20, 30, 40%, 50% plaques, okay? They are perfectly healthy. They can run a long time, or exercise. They're totally asymptomatic and may not have any symptoms, and one day may be at risk for having a heart attack because they have plaques in their body. So those people may not have any symptoms. Now there's something called stable angina. Angina basically is chest pain, and angina is chest pain related to coronary artery disease. And there are 2 types of angina, stable angina and unstable angina. Stable angina is if you have chest pain with activity, for instance, people who have heart disease or who have coronary disease, they can tell you, doc, if I go up 2 flights of stairs, I start having chest pain. And then if I rest, it gets better. And that's their baseline. That is called stable angina. Unfortunately, we can't get them with medicines and therapy to be much chest pain free all the time, and they may end up with stable angina. Unstable angina is different. Unstable angina is you having chest pain at rest or with minimal activity, and you've never had chest pain before, and you having multiple episodes of chest pain. So that's unstable angina. So if you have chest pain and you go to the hospital, your EKG checks out okay, the blood work checks out okay, well, that means that you're not having a heart attack, but you might still have unstable angina that is causing your symptoms. And then the last one is actually having a heart attack. And those symptoms tend to be more severe depending on how massive of a heart attack you're having. And that's related to plaque rupture. So here I want to just quickly tell you, we talked about the blockage in the artery progressively worsening, and that's progressive coronary disease, versus plaque rupture, where the plaque that's nice and smooth, the surface opens up and causes the artery to be blocked 100%, and that's actually having a heart attack. So you can have blockages that are 80% in 3 arteries and may not have crushing chest pain. You may just get tired with walking, okay? Or you may get short of breath going up a flight of stairs, and we do a procedure and we tell you you have 3 blocked arteries that are blocked 80%, and those symptoms are going to be different than you may just have 1 artery that's blocked 40% and goes to 100%, or 80% and goes to 100%. In that case, you have a heart attack, and those symptoms are going to be different. So what are the constellation of symptoms? The classic is the heart sits on the left side of the chest. You have crushing left-sided chest pressure or pain. It feels like somebody's sitting on your chest. The pain may go down to your arm, and usually tends to be left arm, may go up to your left jaw. There may be associated shortness of breath. You may get nauseous with it, get very sweaty, clammy. Those are the classic symptoms of having a heart attack. Now, there are a lot of variations to this because everyone's body is different, everyone's nerve endings are different, and everyone's symptoms are different. Women, for instance, and elderly people, and people who are diabetics don't necessarily have the classic symptom complex that we look for. So what are other things? If you get short of breath with activity, and that's new for you, okay, everyone might be deconditioned and may always get a little tired with activity, but if it's a new finding for you, going up to your bedroom at night, you've always been fine, and now all of a sudden, by the time you get up, you get short of breath, or you might have some chest discomfort, or you feel very drained and very tired with exertion. Well, those might be warning signs that there might be something going on with your heart that needs to be checked into. The other one is, heartburn. People, for whatever reason, commonly, more so younger people than older people, but even older people, may say, oh, it's nothing, it's just my stomach, or I have an upset stomach, or I have a little bit of a heartburn, and just let it go for a couple of days, and you see these people, and I do this for a living, and I see young people coming in with massive heart attacks, and they've had the warning symptoms for a couple of days, which they just said, it's fine. You know, I had a high-power attorney, for instance, from New York, who was down in the shore on vacation, and has been having heartburn for 2 or 3 days and never had heartburn before. He goes, he runs for several miles a day, goes out on a run in the morning, and all of a sudden, the heartburn just massively gets worse, and he actually collapses, and his heart is fibrillating. For all intents and purposes, he died for that moment, but nowadays, we have technology is great. There was an AED available. A lifeguard came, shocked him, and the next thing he was awake again and rushed helicopter to our hospital, and his arteries opened, and he went home 2 days, 3 days later. So it presents very differently, and you know your body best, and you need to know when something isn't right. Well, it needs to be checked into. Other thing about stable coronary disease, or let's say if you have 70% blockage in some artery, those tend to be exertion or emotion-related symptoms. So if they tend to be, oh, doc, when I mow my lawn, I get chest pain, or I get short of breath. Or if something bad happens, if I get emotionally distressed about something, I have chest pain. Those are also worrisome symptoms about coronary disease. So now, how is coronary artery diagnosed? Okay, well, the first thing is easy to do, very cheap and easy, is an EKG. It should be done very quickly in a doctor's office or in an emergency room. Very quickly it's done, and you don't need to know the details of how to read an EKG, but what it tells us, it can tell me if you're having a heart attack, number one. If you've had a heart attack before in the past, it can tell me. If you're having any arrhythmias, it can tell me. It can tell me if your heart is enlarged. So it can give me a lot of information. It's very cheap to do. It's very easy to do. And it can tell me how aggressive I need to be. Based on your EKG, I may not even talk to you for more than 5 minutes and call the ambulance straight to the cath lab because your artery needs to be open. Time is muscle. If you're having a massive heart attack, that needs to be taken care of right away. So there are a lot of subtleties in the EKG, but it's a simple enough thing to do, and that's the first step. Now, clearly, you don't know how to read EKGs, but you can tell that this EKG, which is normal, is quite different from this EKG. This person is having a massive heart attack, the traditional widowmaker that they used to call. Right in the front of the main artery is 100% blocked, and that EKG looks markedly different from the normal EKG. Now, this person, their heart is intermittently having bad arrhythmias, life-threatening arrhythmias that the EKG picked up. So that's something that we can tell. The other thing nowadays that they do when you go into the hospital with chest pain, for instance, is blood work. And the blood work actually tells us that if you're having a heart attack, because the heart muscle, when it gets damaged, it releases these enzymes, the heart muscle enzymes that we can pick up on blood work, and we can tell if you're having if you're having a heart attack and how large of a heart attack you're having. Now, if the EKG it doesn't show anything, and if the blood work is normal, it doesn't mean that you don't have blockages in your heart. You can't stop there, but at least we can tell you're not having a heart attack right now, but what we need to look for is, do you have blockages that are 60, 70, 80% that's causing your symptoms, but not necessarily causing you a heart attack right now. Now, the next step is, as he was mentioning, stress test traditionally is done on a treadmill, and you get EKGs hooked up, you get a blood pressure hooked up, and then you walk on a treadmill. Now, not everyone is able to walk on a treadmill. I'll talk about different types of stress tests, but traditionally, you have them walk, and you get an EKG. What does that tell us? One, it tells us how long can you walk for. Believe it or not, that's the biggest predictor of how well you're going to do. Your functional capacity, how many minutes can you stay on the treadmill for? That tells us your prognosis longer term going forward. Also, we look at the EKG to see if the EKG becomes abnormal with you being on the treadmill. Now, that's the traditional, just the treadmill stress test, but now to improve the accuracy of it, traditionally just the treadmill alone was having and still has a significant amount of false positives and false negatives. So to improve the diagnostic accuracy, we've added imaging to it, and we have two imaging modalities, which I'll talk about here. You can have something called stress echo, which is an ultrasound of your heart that you take pictures before and after the activity or exercise, and you have something called nuclear stress test, and then I'm going to talk about that part as well. Just an example on the EKG, on the left here is normal, and sorry, this is a little too small, but with exercise, the person walked for about 4 or 5 minutes and their EKG started changing, and we can say, okay, we don't need any further data, this is concerning, there's something going on, we need to go to the next step to see if they have coronary disease, but that's very concerning for coronary disease. We talked about the imaging part. Now this is the heart cut, basically a slice through the heart, and we all have 4 chambers. The top 2 are called atria, left atrium and right atrium, and the bottom 2 are ventricles, left ventricle and right ventricles. We all have 4 valves in our body, or in our heart. The 2 valves, one between one between the right atrium and the right ventricle is called the tricuspid valve, and the valve between the left atrium and the left ventricle is called the mitral valve. And then the other 2 valves are up here, and I'm only showing one of the 2. This valve, which sits between the left ventricle and the aorta. So the left ventricle pumps the blood to the aorta and the rest of the body. And the valve that sits there is called the aortic valve. Okay? And what's the function of the valve? Basically, the person who designed all this did it for a reason. So when the heart does its work and pumps, the blood goes out and then the valve closes. So it prevents the blood from coming backwards. It would defeat the purpose if you're pumping on one hand and then that stuff keeps on coming back. So it's a nice system device so that the valve closes. Now you can imagine if the valve becomes narrow, it's an issue. If it starts leaking, it's an issue. And that's a topic for another day about valvular heart disease. But that's just a quick introduction into the inside of your heart. This is the nuclear part. So what happens is with the treadmill, we can do another imaging. So instead of doing the echo, which is an ultrasound, we can do a nuclear scan. And what it is you get an IV and you get a radio tracer injected into your body. And then you get your pictures taken of your heart. And this is what those pictures look like, okay? So this person has a blockage here. So this red is all radioactivity or radio tracer in the heart, okay? And you can see that there's radio tracer from here to here, but there's nothing here, okay? That's concerning that that part of the heart muscle is not getting enough blood because that heart muscle is not taking up the radio tracer. And that's another way we can diagnose coronary artery disease. And if you can't do the treadmill, we have chemical stress tests with either the ultrasound component or the nuclear component. So there are 4 different ways of getting different types of stress tests depending on what you're able to do. Well, lastly, what's the gold standard? So those all have, the treadmill we talked about. The next step up is the stress imaging part, which is better, but it still is not 100%. Okay, it's very good, and I think we are very comfortable with that, but in some people, we may have to go on to the next step, or if the stress test is abnormal, or if they're having a heart attack, then we need to go to the next step, which is cardiac catheterization, okay, or angiography. And what cardiac catheterization is basically is we put a catheter in the groin, in the artery, okay, so it's a large IV, and believe it or not, I haven't had one, hopefully I don't need one, but what patients have said is it's better than going to a dentist in terms of the experience, believe it or not. You get a couple of pinches when you first numb up the groin, but after that you get a little bit of sedation on board and you don't even know they're working on you. It's that smooth. Right. So we put catheters up in the heart, and it goes into the aorta and it goes into these arteries, okay? And that's where we inject dye to look at those arteries and see if they're open or if they have blockages. So let's show you an example here. So that's a catheter that's coming up through the aorta, and it's in the heart, okay? That catheter is sitting in the heart, and it's shooting dye into the heart. And this is not looking for blockages. This is looking for the heart's function. And you can see the heart's pumping well, okay, and that tube looks good. So we do this to see if the heart muscle is enlarged or how the function of the heart is. Now this, on the other hand, is angiography, okay? And what it is, you have that catheter right in the left coronary artery that I told you about, the left main, which branches into the circumflex, which is the one that goes to the side, and the left anterior descending, which is the main artery, okay? So it injects dye into those arteries, and we can see if it's nice and smooth and open or if it actually has blockages there. So that is cardiac catheterization or angiography. Now, technology is evolving and changing. So instead of doing a catheterization in some patients, now not everyone, and it's a very sub-selected group of patients, we can do a CAT scan. It's an angiography with a CAT scan. Okay, it's called CT angiography. The benefit there is that you're not getting a needle stuck in the groin, you're not getting wires in your heart. Unfortunately, the radiation and the dye is still given with the CAT scan. So it's not for everyone, but in some patients you can do a CT angiography, and that's what the arteries look like on that. And just like the catheterization, this is a CAT scan. You can tell if there's a blockage or a plaque there. And this is a cross-section. The white part is the open artery. All the black stuff is blockage around that. Okay, it's a very tiny hole there. And that correlates with catheterization. Now this is catheterization, and this is CAT scan. And you can see how they could be similar, and they complement. So that's in terms of diagnosis. Now let's quickly move on to treatment. Now we talked about diagnosis. What do we do with treatment? Believe it or not, after all of these sort of discoveries and cardiology, it's amazing, and one of the reasons why I went into the field is compared to other subspecialties or other fields of medicine, cardiology is far above and beyond in terms of the research that we've done, in terms of the data that we have. We have, I mean, in terms of survival rates and what we have done 10, 15, 20 years before and now, it's amazing what we were able to do. But what I want to drive at here is that after all of this, what we have come down to is that in some people, medical therapy works equally as good as doing all these aggressive things. You know, putting stents in people, doing bypasses, all of this, and you may say, well, did you really help that person live longer? And so there's a difference, and I think that each person has to be individualized, but putting stents in doesn't necessarily make someone live longer, okay? It may improve their quality of life in terms of if they have angina, it may get rid of the angina, but it doesn't necessarily make them live longer unless the blockage was in a critical area of the heart where doing a bypass or a stent does improve survival, okay? But what I'm trying to drive at is nowadays we have very good medical therapy, and for people with stable disease, we might be able to get away with just medicines alone and may not have to do all of these high-risk procedures. So it's individual dependent. And what are the medications? I mean, these medications have been around for a long time. Aspirin has been around for decades, okay? There are medicines called beta blockers. So examples, atenolol, metoprolol, carvedilol. Now these are people who have coronary disease, not people who don't have it, don't necessarily need to be on these medications. Statins came around 15, 20 years ago, and they're wonderful drugs. They work remarkably well, and what they do is they prevent that plaque from rupturing. They lower the inflammation. So people think, well, it's a cholesterol medicine. My cholesterol is perfectly fine. Why do I need a cholesterol medicine? Well, it does a lot more than just lowering the cholesterol, okay? It actually lowers the inflammation in the plaque, so it lowers the risk of that plaque rupturing. It lowers the risk of you having a heart attack. So depending on your risk profile, you need to be on that medicine. So what are the examples? Simvastatin, which is Zocor, atorvastatin, which is Lipitor, rosuvastatin, which is Crestor, and I just put 3 examples there. There's another class of medicines called ACE inhibitors. Lisinopril, enalapril, ramipril are good examples, and they are good for your heart. And lastly, there's clopidogrel, which is Plavix. Now, everyone needs to be on this. If you've had a stent before, or if you have severe disease, or if you've had a heart attack recently, then you may benefit from this medicine. It's very expensive, and not everyone necessarily needs to be on that. And then the last 2 are angioplasty or a stent, which is actually finding the blockage and fixing it. Now, if you're having a heart attack, all my theory about medical therapy goes out the window. Now, you still need medical therapy, but you have a problem, that blockage needs to be fixed. Otherwise, that part of the heart muscle is going to die. Okay, so there are people who definitely need those life-saving interventions, and there truly are life-saving. I was talking more in terms of people who have stable disease that you can get away with medical therapy. So you have angioplasty or stent or bypass surgery, and I'm just going to show you a couple of quick slides. This one is not going to project that well, but you can see that there's plaque here. And what a stent is basically a ballpoint pen. If you open it, there's a little spring in there. Okay, that's what a stent is. The stent looks like. And through the artery, we can put that and make that bigger. So first we do a balloon through the plaque or blockage, crush that open, and then we put a stent in there to keep that plaque against the wall and open up the lumen. So you can see how the lumen has gone from this size to this size here. And I will quickly show you an example. This may not project too well back here, but if you stare at it enough, there's a high 80–90% blockage right there. If you compare it to this side of the catheter to that side, do you see that there's an area that's not filling completely? You guys see that? Okay, so that's a 90% blockage in, for instance, what you call the widowmaker, right at the beginning of the left anterior descending artery. So that needs to be taken care of. So what we do, so that's the first picture. The second picture is we put a wire down. It's a very thin filamentous wire that goes down that artery, okay? And then, so now you see the wire. It's a little wire that's sticking out that way. And then the next step after the wire is you balloon it. And that's what the balloon is going up right there. You can see the balloon. And then the stent looks similar. I don't have a picture of that. But then the ultimate result, this is the same patient, same view, and you can see what happened to that blockage that was there before and what it looks like now. That's what angiography and stenting is. And then what you have is bypass surgery. And what is bypass surgery? Now, without going into all the details, it is open heart surgery. Your sternum, so you're put under, your sternum is cut open, Okay, the heart is exposed. The heart is put on bypass. So you're on a heart-lung machine for that amount of time, and so that the heart doesn't beat anymore. And what they do is they take a vein out of your leg or an artery that runs on the inside of your chest wall, and they bypass the area where the blockage is. So they'll put that bypass after the blockage, okay? And they'll take that vein, tie it to the aorta, and bypass the blockage. So if the blockage is here, now this part of the heart gets enough blood flow because that blockage has been bypassed, and that's where the name bypass surgery came from, okay? And this is another zoom up, and you can see there's a plaque here, okay? Here's the aorta. They've taken a vein from your leg. They've attached one end to the aorta, and directly, it's like you forming your own coronary artery, okay? It touches down beyond the blockage, and then that part of the heart muscle gets enough blood flow, and that's what bypass surgery does. And then lastly, one may ask, well, how about are there novel things out there that may pick up heart disease early? These are the people who have 30s, 40s, people in their 30s, 40s, 50s, who are young and healthy otherwise, but they have bad family history of heart disease. And you may say, well, doc, you can go through my traditional risk factors. I don't have that many, but I can tell you, my dad had his first heart attack at 40, and he wasn't a smoker. Or, I have had 3 people in my family that first degree relatives with heart disease. Is there anything you can do for me to diagnose this early on? So there are some things that we can do. I talk about inflammation, and there's a blood test that can be checked to see if you have a lot of inflammation, and you can guide your therapy based on inflammation. And now this is all individual patient dependent. We can't just generically do it for everyone because you have to be careful what you're looking for, and you have to be ready to act on it because if you start randomly looking for information, then you might start over-treating people. So you selectively have to find somebody who will benefit from that and then do it. But I do it for certain selective patients. There's something called coronary calcium score. Okay, it doesn't have much radiation at all. It is a CAT scan, but it's a very quick CAT scan. And what it does is it looks for calcium in your arteries. Okay, and based on that, I can tell if you are at if you already have coronary disease and how extensive it is. And it's not invasive. Unfortunate thing is insurance doesn't pay for it. So you're looking at about $200, $300, $400 to do a coronary calcium score. But this, in someone who's 40 years old and has family history and wants to really know if they have coronary disease or if they have the beginning of coronary disease so they can start taking those cholesterol medicines early, then this might be a worthwhile investment. There's also something we can do, an ultrasound of the neck that can tell us if you have plaque in the neck or if you already have thickening of the wall. That tells us there's plaque building up inside, and we are more aggressive with those people. So, summary slide here. Coronary disease or atherosclerosis is very prevalent. Okay, it's the leading cause of death in the United States and worldwide, much higher than any other causes, including cancer. So it's very prevalent. It's a gradual, progressive process that starts very early, okay, as early as teenage years. So I think we have to appreciate that and act accordingly. But we do know the risk factors. It's not like it's a condition. There are many other diseases, unfortunately, that we just don't know enough about. And that's because the research hasn't been there and it's not as common. But I'm sure that you all know family members who may have a disease that there's not much known about and not much you can do about. But coronary disease is one that a lot is known about. And you know the risk factors and you can prevent it or screen for it early. Early screening is key. And then lastly, what we've made strides in is that if you diagnose a problem early on and get these people on effective therapy, you can really improve their survival, long-term survival, and also their heart function long-term. So early diagnosis and effective therapy. Now therapy varies and you want to make sure you're getting the right treatment and the right things and what's evidence-based as opposed to sort of random trial. But the nice thing in coronary disease is that most physicians do practice evidence-based medicine and most patients are on good quality of medications and receive good quality of care. And that's it.